think.
Even a temporary, there is one more.
1 minute more, sir.
1 minute.
1 minute more.
So, the implications of such transmissions is like family history. In future, taking the family history shouldn't stop with just ancestral father or grandfather. It has to take into account the entire ancestral environment too. So just having diabetes in father or grandfather is not enough. A non-diabetic grandfather exposed to a famine or overeating could be a risk here. So we will have to be very clear in taking that history also. And of course, we have been very diligent in treating the GDM or whatever it is, metabolic abnormality in the mother. Now we will have to prepone it while planning the pregnancy itself. So these epigenetic, that's it sir, finished sir. So these epigenetic interventions can mitigate the disease. The future is epigenetic modification, sRNA biomarker discovery, and of course ethical framing. So what is the take home message? So if you are ill, don't feel guilty, blame your grandpa. And of course, if you don't want your offsprings or your grandsons to be ill, try to get your children married before they develop any metabolic abnormalities. So get them married early.
Thank you, Dr. Vengo sir.
Thank you
for your nice presentation and very new informations and insight into this very good but different and unusual topic. Next I call upon Dr. Joseph Panneerselvam sir, diabetologist from Trichy, and he is going to talk on metabolic surgeries.
A very good morning, one and all. At the outset, I would like to thank the organizing team of TRAC 2025 and Balamurugan sir for giving me the opportunity. So my topic is metabolic surgery. As we all know, so the obesity is and related type 2 diabetes and other disorders, they are increasing in a pandemic proportion. So we have medical management of obesity and these disorders, but they are not adequate to address the complications. So now the focus is shifted to metabolic surgery. Actually, it's not a new concept. So these surgeries have been started in 1960s itself. So we are going to discuss. So I'm going to discuss about this metabolic surgery. What's the role of metabolic surgery in treating obesity and related metabolic conditions? This is all the agenda. So the obesity and type 2 DM, they go in hand in hand. So metabolic surgery is an important option to achieve substantial and durable weight loss, because the medical management may not be able to bring about desired weight loss. So the substantial and durable weight loss is possible with the metabolic surgery. So the mechanism seems to extend beyond weight loss, and the reduction in CV risk factors translates to better outcome if we go for metabolic surgery. And what is metabolic surgery? So these are the range of procedures that modify the stomach or small intestine to either restrict food intake or reduce nutrient absorption, or both. These are the very important mechanisms. Either they have to restrict the procedure, they have to restrict the food intake or reduce the nutrient absorption from the duodenum, or some of the procedures they provide both. Lead to significant weight loss and improvement in metabolic conditions like type 2 DM, hypertension, obesity and sleep apnea and other related disorders. So the pathophysiology of obesity is very complex. So the many factors they contribute to the development of obesity, like environment, epigenetic, genetic, physiologic, socio-cultural, and so many factors are responsible for the development of obesity. So the obesity is graded by using body mass index. So the normal BMI is 18.5 to 25, and overweight 25 to 30, and class 1 30 to 34, 34.9, class 2 obesity is 35 to 40. Any BMI more than 40 is classified as morbid obesity or class 3 obesity. These metabolic surgeries, they play a very important role in the last two categories. So either morbid obesity or patients with class 2 obesity with comorbid conditions. So these are all the obesity associated conditions. So the type 2 DM, hypertension, dyslipidemia, obstructive sleep apnea, arthritis, GERD, non-alcoholic fatty liver disease, PCOS, and clinical depression and functional impairment. These are all the concepts or disease conditions associated with the obesity. And it can produce variety of complications from head to foot. So all the systems are involved. So with the obesity, so we have to find ways to control this obesity to prevent these complications. And we have medical management. So variety of drugs are available for the treatment of obesity, but they are not adequate. So these are some of the limitations. So the weight loss is only the modest. So only we can achieve modest weight loss, and often it is not durable. Whenever the patient stop the medications, there will be rebound increase in the weight. So the drug intolerance adverse effects also one of the reason for the non-compliance from the patient side, because we have many drugs starting from orlistat and this phentermine, and recently GLP-1 receptor agonist also they are using for weight loss. But the drug intolerance is a major issue, like GI disturbances can occur, patient can have diarrhea and bloating abdomen. All these things that the complaints be decreased from the patient side. So they have got different efficacy and safety profiles. No general treatment algorithm is available, because the treatment should be individualized. For each patient will require different treatment approach. These are some of the limitations of medical management. And what are the benefits of metabolic surgery? So it provides significant and greater weight loss. So up to even 50 to we can achieve 50 to 60 kg weight loss also maximum, and it improves diabetes control, and it can achieve remission in majority of the diabetic patients after metabolic surgery. So many patients, so they remain free from diabetes. So remission can be achieved, and there will be improvements in other obesity and related conditions such as hypertension, and even the cancer incidence also will come down significantly. So the patient will have better quality of life, and the sense of well-being, physical well-being will be there after metabolic surgery. And what's the rationale for metabolic surgery? So due to the tendency for basal metabolic rate to decrease with the dieting, most people will regain all their weight returning to the previous homeostatic set point. This is the problem with medical management. Whenever we perform metabolic surgery, it appears to alter this mechanism and reset this point. So the points will be reset with the 15 to 20% of weight loss and maintenance up to 20 years. So the weight loss is durable over the period of 20 years. This leads to long-term survival benefit and improves obesity-related diseases and quality in life. And there are various mechanisms. So for this metabolic surgery, so it extends beyond weight loss. It's not only weight loss. So it is the benefits are beyond weight loss. It causes depletion of liver fat and subsequent improvements in the hepatic insulin sensitivity and clearance. There will be very good improvement in the insulin sensitivity. So the improved incretin levels is another factor responsible for the better outcome, and the changes in the inflammatory and adipokine profiles also noted. This is the flow chart. So after performing metabolic surgery, it causes, so the patient will decrease the calories and increase ileal nutrient delivery instead of duodenum. So there will be malabsorption, and there will be increase in bile acids, and gut microbiota also improved. So the ultimate results are decrease in weight, increase in incretins, and decrease in insulin resistance, and increase in insulin secretion. Ultimately, it causes diabetes remission or improvement, and so the final result is decreased cardiovascular events and decreased mortality. So this is what are the inclusion criteria. So the patients, you have to select the patients correctly for better outcome. The age should be between 18 and 60 years, and body mass index should be more than 40. That means morbid obesity, and the patients BMI of more than 35 with the significant comorbidities such as heart disease, diabetes, hypertension, sleep apnea, and so on. And there's we can consider metabolic surgery if the patients with the BMI of between 30 and 35 if their diabetes is poorly controlled with the available means. The history of prior weight management attempts and motivation and engagement in lifestyle modification. So we can select these patients from this category. And what are the exclusion criteria? So patients already having cardiopulmonary disease and current usage of illicit drugs, tobacco use, and alcohol use patients should be excluded from this treatment. And lack of comprehension, reversible endocrine disorders with obesity, because this is a reversible cause, we need not do complex metabolic surgery in this group. So uncontrolled severe psychiatric illness is also a contraindication. And this is algorithm how to select the treatment option for patients with obesity. So we have to divide based on the BMI. If the patient's BMI is less than 30, so we can go for non-surgical management. If it is more than 30, so we have to divide whether it is class 1, class 2 and class 3. So class 3 patients, straight away we can recommend metabolic surgery. And class 2 patients, if the lifestyle management and medical management is not sufficient, so we can recommend metabolic surgery. And in patients with class 2 and class 1 obesity with the poor glycemic control, we can consider doing metabolic surgery. This is algorithmic approach. And what are the surgical options available? So we have 3 mechanisms by which the surgical procedures work. One is restrictive procedures. That means we are restricting the intake of the so by restricting the capacity of the stomach by performing sleeve gastrectomy and gastric band surgery and vertical band gastroplasty. And malabsorptive procedures, the bypass, jejunal-ileal bypass will be done to bypass the duodenum. It prevents the absorption and causes malnutrition. That way it improves the weight loss. So some of the procedures, so they provide both restrictive and malabsorptive. The examples are Roux-en-Y gastric bypass surgery, duodenal switch surgery and sleeve bipartition. We'll discuss one by one. So this is a Roux-en-Y gastric bypass surgery. It started way back in the year 1960s. So here they will construct a small pouch in the proximal stomach and they will connect it to the distal jejunum by bypassing duodenum and proximal jejunum. So thereby it causes both restriction of intake as well as so the absorption defect. Thereby it works very well. So it provides a greater weight loss up to 60 to 80% and changes in the gut hormones that reduce appetite and enhance satiety and typical maintenance of more than 50% excess weight loss. The disadvantages are the procedure is very complex and it can produce vitamin and mineral deficiencies. It requires longer hospital stay and some of the patients they can develop internal hernias also. The next one is sleeve gastrectomy. Here along the lesser curvature, so they will resect the greater curvature. 70 to 80% of the stomach is resected. The remaining part of the stomach will form as a sleeve. So it's a very small portion. So there will be restricted intake, and there won't be any malabsorption here. Only the intake will be restricted. This procedure also started in 1960. Here also the significant weight loss can be achieved. So the hospital stay is shorter, and it changes the gut hormones to improve the satiety. So it will reset this neurohormonal mechanism, thereby it improves the satiety and causes weight loss. So disadvantage is a non-reversible procedure because the greater curvature of the stomach is resected, so it cannot be reversed. And again it can produce vitamin deficiency, there will be leak and potential weight regain also is there. It's the disadvantage. And the third one is the duodenal switch. Here also they will perform the jejunal-ileal bypass to bypass the nutrition absorption from the duodenum. And again it provides greater weight loss, and this allows patient to eat near normal meal because the stomach capacity is not restricted. Disadvantages are higher complication rates and the risk of mortality. It requires longer hospital stay. It's a complex surgery. And this one, next one is vertical band gastroplasty. Again, so they form as a pouch, small pouch, by stapling the stomach in the proximal portion. Thereby their intake will be restricted, and so there will be restrict the caloric intake, and it provides weight loss by this mechanism. So the last one is adjustable celastic gastric band. It's a very simple procedure. So they will fix a band in the proximal stomach to restrict the stomach quantity, and the port placed under the skin. So we can adjust, we can inflate the pump. So by injecting saline, so it can be inflated or deflated. So by this mechanism, the stomach capacity is restricted. So there will be decreased intake and ultimate weight loss. So what are the clinical trials data to support? So this is a 5-year, they have studied, in this trial they have studied 5-year changes in body weight and the rates of diabetic remission and changes in glycated hemoglobin. The first one is changes in body weight. So it's a greater weight loss achieved.
Joseph sir,
yes.
Kindly finish it in another one
yes.
more minute.
Okay. So the next one is the diabetes remission. Remission at the end of 5 years is very much greater in patients, those who are undergoing this procedure. And the changes in glycated hemoglobin also is significant by this procedures compared to the medical management. And what are the complications? So there can be general complications like sepsis, bleeding, cardiopulmonary, and death also. The rate of death should be very, very low in the appropriate setup. These are the potential complications associated with this specific type of this surgery, like strictures, band erosion, gallstone formation is very important, side effects in all these procedures, and gastrogastric fistula and marginal ulcer, nutrition deficiencies, all these things can occur. We should be aware of this and provide the adequate nutritional supplement after the surgery. And what are the results? So the mean ratio of patients to the resolution of the type 2 diabetes remission can be achieved 48% with the gastric banding, and vertical band gastroplasty 68%. The maximum of 98% remission can be achieved with this duodenal switch surgery. And we can achieve the non-glycemic effects also. So the there will be improvement in hyperlipidemia and hypertension. So these are the take-home messages. So when the behavioral and the pharmacology interventions fail to manage, we can consider bariatric surgery, and the careful patient selection is very much important for the better outcome and to prevent the complications. Those bypass techniques improves glucose homeostasis through mechanisms beyond reduced caloric intake and weight loss. So thank you for the patient listening.
Well, thank you, Dr. Joseph, for a good talk. Who is going to talk on polypharmacy, and I think the polypharmacy has become mandatory nowadays, and we cannot avoid it. Of course, with the advent of AI, in few years' time or in a few months' time, the patients will be sitting in front of us talking about drug interactions and so on. We should be prepared for that. Let's see what Artikaran says about it. Thank you.
Adults worldwide, hence necessitating more innovative therapeutic approaches. The limitations of the current treatment approaches are the monotherapy limitations, that is single target medications which offer insufficient glycemic control, and the treatment burden of multiple tablets, poor adherence, increased cost, higher risk of drug interactions and adverse effects, and also inadequate weight management because of our traditional diabetic medications, hence failing to address the obesity component. So these limitations highlight the urgent need to bring about more comprehensive treatment strategies to address the multiple aspects of metabolic dysfunction. So as the years have gone by in the last 2 decades, obesity management, we start with lifestyle changes, then behavioral therapy, which has found to cause only 3 to 5% of weight loss. So we have started them on pharmacotherapies, and the older pharmacotherapies we had did cause only about 5 to 10% weight loss. In the last few years, we have seen a great leap, that is in the development of new molecules like the GLP-1 analogs, which are showing a very big ray of hope for our type 2 diabetic obese patients, and the newer molecules which actually revolve around this GLP-1 analog is going to actually replace even bariatric surgery soon. So recent research has revealed complex interactions between the brain and the body in regulating hunger and energy use. The discovery of leptin initially did raise hopes because it promotes fullness and increased energy burn. However, its effect in obesity was found to be limited. So now going on to the paradigm shift of this unimolecular polypharmacy, it is a single molecule engineered to activate multiple receptor target, and each component of the molecule do not interact with each other. They act separately on their receptors, and they maintain their individual identity and integrity. They overcome the limitations of traditional pharmacy. Polypharmacy provides synergistic effects, simplifies treatment regimens, improved adherence, and reduces the pill burden too. So going on to this GLP-1 analogs, they are mainly produced by the intestine in response to food. They cause glucose-dependent insulin release, they slow the gastric emptying, reduces the postprandial glucose exertion, acts on the hypothalamus, and induces satiety and reduces the food intake too. These are the drugs which are available with us today, and also with tirzepatide. This schematic representation shows how a peptide-peptide multi-agonist approach did offer beneficial metabolic profile by targeting the multiple receptors. Let me talk to you about them in a little detail. Going on the milestones of GLP-1, they came into play from 1987, and starting with the exenatide, the liraglutide, then came the semaglutide, and the tirzepatide today. GIP is also produced by small intestine, has potent incretin effects, promotes beta cell proliferation and survival, modulates adipocyte metabolism and fat deposition. So these two together, GLP-1 with GIP, the dual agonists, despite their double incretin action, neither caused chronic hyperinsulinemia nor hypoglycemia has been observed in various trials. So what does this complementary action actually do? It has a synergistic effect of greater insulin secretion, more adipogenic effects, and also has a multi-organ impact. So this dual agonists have shown superior efficacy in the treatment than when they use the other two molecules separately. So incretin effect is nothing but enhanced insulin secretion after glucose load, and 70% of the postprandial insulin secretion is mainly because of GLP and GIP, and this incretin effect is actually impaired in type 2 diabetics, and this dual agonist has found to actually restore this compromise. And beyond the glycemic control, it acts on the central nervous system, crosses the blood-brain barrier, it acts on the hypothalamus, causes appetite regulation, acts on the brainstem, causes satiety, acts on the mesolimbic system, and modifies the food preference. And the drug we have today in this dual agonist is tirzepatide, which is found to affect type 2 diabetes, obesity, and other metabolic diseases too, which has been proved by the SURPASS program, SURPASS CVOT, SURMOUNT program, and for the other comorbidities, we have ongoing trials. The next dual agonist will be GLP-1 with glucagon. So along with the functions of GLP-1, we talks with glucagon, which is found to increase glucose production, satiety, and also the energy expenditure. And both these dual agonism has found to safely improve the glucose tolerance, hyperinsulinemia, hepatic steatosis, and body weight in various preclinical data. The drugs we have today in the pipeline, the phase 2 trials are cotatudide, pemvidutide, and the survodutide. So the comparative efficacy of the single target therapies to the dual agonists have shown higher HbA1c reduction of 2.3% and a weight loss of about 15 kg. So hence excellent glycemic control and weight reduction. Next combination dual agonist will be a GLP-1 with steroid that's along with estrogen. Estrogen is found to have leptin-like effect and also found to protect the pancreatic cells from the damage associated with the metabolic disease. But the adverse effects of estrogen like uterine hypertrophy and accelerated growth of estrogen-sensitive xenograft tumors have limited its use. Going into the combination of a GLP-1 with amylin, which is also secreted by the beta cells, this hybrid peptide has shown to improve insulin sensitivity, increase the satiety, reduce appetite, and the energy intake. And the molecule we have is cagrilintide and amycretin. These have shown in the redefined 1 and 2 trials excellent weight loss of 20.4%. Even amycretin has shown a weight loss of 24.3%. The next dual agonist on the pipeline is GLP-1 with CCK, which is an anorexic hormone secreted by the intestinal cells, and this hybrid peptide has also shown superior weight reduction. But we need more clinical data to see on its effects, to see the effects of the gallbladder with this combination. The next on the pipeline is GLP-1 with fibroblast growth factor 21. For this is actually secreted by the liver, regulates fatty acid oxidation and glucose oxidation, has anti-inflammatory role too. And this dual agonist in the phase 2 trial has shown very promising results in reducing the hepatic fat, improving the liver injury markers, and the metabolic parameters in NASH as well as type 2 diabetic patients. Next we have the monoclonal antibody peptide conjugate, maritide, which in the phase 1 and phase 2 trials have shown acceptable safety, tolerability profile, and dose-dependent weight loss. Phase 2 trials are still going on. Going on to the bimagrumab, this has another excellent monoclonal antibody which has been combined with GLP-1, which has shown weight loss with muscle preservation. So in the BELIEVE 2 trial, it has shown to cause excellent weight loss of 22%, and along with the reduction of abdominal fat and inflammation-related biomarkers. So here I give you a list of the monoclonal antibodies which are still on the pipeline, yet to come into field. And next we go on to, after the dual agonist, we go on to the triagonist. That is the combined GLP-1, GIP, and the glucagon. And And this, the drug we have, this is retatrutide. In the phase 2 trials, it has shown a weight reduction of 24% and also reduction in the BP, lipids, as well as good glycemic control. Here I have just summarized the multi-receptor agonists, which I've spoken in detail, which shows the effective glycemic control, effective weight loss, and also its other metabolic effects too. Going on to the next combination of tetra-agonists. Here they have combined GLP-1, amylin, GIP-1 and calcitonin. This category has shown the highest quality of weight loss with reduction of fat mass, preservation of muscle mass, and also improvement of the metabolic health of a patient. So you can see this diagram, you can see a single molecule is targeting multiple organs in our body. So next combination we'll be seeing is GLP-1 with basal insulins. Some of them are in the pipeline. Some have come like Igarlexi, Ideglera. Most of you must be using. And just to say, this combination of basal insulin has been addressing out of the 7 out of the 8 pathophysiological abnormalities of type 2 DM has been addressed by this combination of GLP-1 with basal insulins. Other than only glycemic control, it is going to cause weight loss, also lesser hypoglycemias and improved GI tolerability too, which has been proved by the solid D trial, Lixican-L, Solimix trial have all proved the above. So here I give a list of the key unimolecular combination drugs in the pipeline, in which we have only tirzepatide today with us. Others are still in the phase 2 and phase 3 trials yet to come to us. Does this unimolecular polypharmacy play a role only for obese type 2 diabetic patients? No. It has found a promising role in neurodegenerative disorders, infectious diseases, respiratory diseases, cardiovascular diseases, oncology, and also in metabolic disorders. So the future of our new metabolic therapies is metabolic disease treatment is shifting from symptom management to comprehensive metabolic control. It does offer a broader disease coverage, patient-centric and precision approaches, bariatric surgery-like efficacy with medications and expanded therapeutic impact. Numerous monitoring promising therapies are in the clinical pipeline have been posed for regulatory review. Our field is entering into a new era of effective, convenient, personalized metabolic care, less burden, improved adherence, and ongoing innovation. Thank you very much for your patient hearing. And I will not be doing justice to my talk if I do not pay my gratitude to my guru, my teacher, my mentor, without whom this full talk would not have come out. The best teachers are those who inspire us to be our best selves. Thank you, sir, for being a constant source of my inspiration. Thank you to all.
Thank you for finishing in time, and we have open forum now. Any questions?
Thank you, madam. Thank you for your extensive presentation. Just one practical question regarding the presently available anti-obesity drugs. After achieving weight loss, whether the patients are able to sustain